All right, everyone, welcome back. Let's take a look at the ventricular rhythms in this video. So as we've done, we're going to start with essentially the baseline rhythm. In this case, it's going to be idioventricular rhythm. And then we're going to change the rates a little bit, and we're going to call them different things. All right, so these are the rhythms we're going to look at. We're going to look at idioventricular rhythm. We'll also mention what this ventricular escape business is. It'll just be similar to the junctional escape stuff that we talked about in the previous video. We'll look at accelerated idioventricular rhythm. We'll look at the ever famous ventricular tachycardia. We'll look at ventricular fibrillation. And then we'll look at something that's not even a rhythm, but the premature ventricular complex. Last but not least, we'll talk a little bit about asystole and then this concept of pulseless electrical activity, which is not a rhythm in and of itself. It's a condition. All right, so we'll talk about those as we get there. All right, so first thing I want to refresh your memory on is that now we're talking about something that's going to come about from the ventricular tissue. So before we talked about SA node, we talked about atrial, we talked about AV junction. Now we're looking at stuff that's coming from either interventricular septum or ventricular walls itself. We're talking about ventricular tissue, and remember that ventricular tissue kind of has this inherent firing rate of somewhere like 20 to 40 beats per minute. All right, so keep that in the back of your minds. And let's take a look at our first one. So we're going to follow this 5-step method as we do every single time. And this is called idioventricular rhythm. All right, so idioventricular rhythm is characterized by a rate less than 40 beats per minute. It's going to be extremely regular. There are going to be no P waves, therefore no PR duration, and the QRS complex is going to be longer than 120 milliseconds, which, if you'll recall, is 3 small boxes. All right, so let's take a look here. As we look at this EKG trace, we can very quickly see that the rate is very slow. We're at like 300, 150, 175, 60, 50, 47, 43. We're like right around the 37, 35 mark. All right, I'm going to put it right around 37 per minute. All right, it's very regular. If we look at the distance between these R waves, it's extremely regular, so that satisfies this and this requirement. There are no P waves anywhere to be found in here. No P waves to be found anywhere. So that satisfies that requirement and that requirement. And last but not least, we have to look at the QRS duration. Now this QRS duration is a little bit funny because in the previous video, what I told you is that if you can't really tell where the QRS ends, then you always go back to the baseline. Now, in this case, I'm going to give you a little bit of a different rule, and that is if there is an acute departure, so let's figure out where it starts right here. If we follow this QRS complex and there's an acute angle change, see this acute angle change that takes place here, this is where I'm going to call it quits on my QRS complex. So I'm going to put a line there, and I'm going to put a line there, and I'm going to say that actually that's where these are marching out. So if you look at this, these guys kind of line up here, and they line up right around here. We're looking at 1, 2, 3, 4, or about 160 milliseconds. Again, satisfies that requirement. So if you look at this really wide QRS complex that's really slow, and there's one other thing I want you to appreciate here, and that is that in the ventricular rhythms, much like you'll see in the paced rhythms, there is discordance between the QRS complex and the T waves. There's discordance, meaning that one faces up, the other faces down. This is pretty characteristic of activity coming from the ventricles. All right, so look for discordance between QRS and T waves. All right, this tells us about ventricular activity. So idioventricular activity, ventricular activity has this discordance that takes place, and discordance tells us about opposing forces between depolarization and repolarization. All right, so we'll see idioventricular escape rhythms here in just a little while when we talk about heart blocks, but I'll just mention briefly, again, if we have an underlying rhythm, and that underlying rhythm shows us no sinus activity, no AV junctional activity, but we do see that there's ventricular activity as a result of the fact that these guys aren't working, then we call that an escape rhythm, meaning that the heart escapes to this next pacemaker site. So primary pacemaker, SA node, when it ceases to function, secondary or backup is the AV junction. When that ceases to function, then the heart escapes to the next piece, which is the ventricular tissue. So an idioventricular escape rhythm is a rhythm that comes about when these guys aren't getting their signals through to the ventricles. All right, and we'll see that in just a little while in heart block. I'll show you very clearly what that looks like. All right, so as the name implies here, accelerated idioventricular rhythm is nothing more and nothing less than a change in the rate. All right, so the regularity is going to stay the same. There are going to be no P waves, no PR duration, and the QRS complex is going to be wide, so greater than 120 milliseconds. And then the only difference here is that the rate is going to be in excess of 40 per minute. All right, so let's take a look here. Are there any P waves here? If we look here, there's absolutely no semblance of a P wave. There are these little blips here. I'm going to call them little hiccups. There's absolutely no P wave that you would find, a normal-looking P wave, anywhere on this tracing. All right, now, what we need to find out is what the rate is here. So let's just count them out. We'll count at 300, 150, 100, 75, 60. We're right around the 50 mark here, so we're a little bit over 50. Let's call it about 52 per minute. So, man, that satisfies this requirement, and this requirement. And now we need to look at regularity. So if we were to map this out, the distance actually between the R waves is spot on, all right? And therefore, we have a regular rhythm here. Last but not least, let's take a look at our QRS duration. I'm going to mark them right around here. All right, so that's where our J point is. That's the beginning of the R wave. And I'm going to calculate this to be about 1, 2, 3, again, about 4 small boxes. So let's call that 160 milliseconds. Again, accelerated idioventricular is no different than idioventricular rhythm, except for one factor, and that is the underlying rate must be above 40. So you should ask yourself here, how can I differentiate, for example, a sinus brady from an accelerated idioventricular rhythm? Because sinus brady can hover in the 50s, and sinus brady and accelerated ventricular, if they're the same rate, how do we differentiate them? And the answer is, in sinus bradycardia, you get P waves. In accelerated ventricular, you do not. Therefore, in Brady, you get PR intervals. In accelerated idioventricular, you do not. In sinus Brady, you get a narrow QRS, something that's less than 120 milliseconds. In accelerated idioventricular, you get something wide. So then the next question you should ask yourself is then, how do I differentiate a junctional rhythm, which can also hover in the 50s, from either sinus Brady or accelerated idioventricular? And we would just repeat the same process. It's not a rate-dependent change. It's going to be a P wave presence or inversion. A P wave absence in junctional rhythm is not going to give us what we want, but the P wave that's inverted will allow us to differentiate the junctional from accelerated idioventricular. Or if there's a P wave, it's going to allow us to differentiate it from sinus Brady and junctional. And then in addition to that, if we have a QRS complex here, we're going to say it's going to be around 120-ish, all right? Really less than 120, 100, 120 milliseconds. And in an accelerated idioventricular, it's going to be wide. The other thing I want to draw your attention to is that in sinus Brady, you should get something that looks like this with respect to QRS and T wave. They should both point in the same direction. Remember that ventricular rhythms oppose one another. Negatively deflected, positively oriented. Negatively deflected, positively oriented. So discordance is something that you only see in these ventricular rhythms. In the junctional and the bradycardic rhythms, sinus bradycardic rhythms, we end up with concordance. That's when the QRS is up, T is up. All right, so let's move on. One of my favorites. So this is ventricular tachycardia. Ventricular tachycardia comes in two flavors, a monomorphic, all right, mono, one. Morph means shape, so monomorphic means one shape. And if you look at this, you'll see that, in fact, if you look at the peaks to the troughs here, they're pretty much all the same shape. Now, there's a little bit of movement in the baseline, and that's what gives it an appearance of different amplitudes. But the amplitude, I assure you, if you measure them across here, they're all exactly the same. So one amplitude or one shape, ventricular tachycardia. So let's take a look at this. The characteristic findings of VTAC, the regularity is extremely regular. No P waves for now. We're going to talk more about dissociation of P waves, and we'll talk about AV dissociation later. I don't want to confuse things for now. We're going to call this an absence of P waves. therefore an absence of an absence of PR intervals. And then the next thing we want to look at is the QRS duration. Well, you already know that all ventricular rhythms have wide QRSs, so these are going to be greater than 120 milliseconds. Last but not least, for the most part, the rate is going to be right around 120. Right? So I shouldn't write necessarily greater than. It may be more than 120, but man, VTAC loves to hang out like the 120 to 150-ish, 160-ish range. It is possible to have VTAC in the 100 range. That's called slow VTAC. Generally speaking, though, VTAC loves to hang out right around the 120, 130, 140 range. All right, so let's take a look up here. Now, you're going to find it difficult to capture where the QRS ends and where it begins, and I would agree with you. In that case, this is what you do. Here's a trick. You find the total amplitude. You find the midpoint of that amplitude. At the midpoint of that amplitude, or right around the midpoint of that amplitude, you're going to find where the QRS complex intersects the baseline. Right? That's this isoelectric line that exists. And if you do that, you'll notice that these guys are right around 130 milliseconds in duration. You'll notice that the rate here is right around the 160-ish mark. All right, this would be, let's say, 300. This would be 150. So it's right around 160. So this is a little bit fast. You're okay with that, but it's got to be over 120. That's the important piece. So 160 is okay as well. All right, ventricular tachycardia. So monomorphic VTAC is characterized by a rate in excess of 120 that is very regular. This is really, really important at this stage that you understand the regularity piece, because there are going to be some things that look exactly like this, but they will be irregular. It's going to be a different rhythm. Treatment is completely different. Everything's different about it. There are no P waves in here for now. There's no PR duration, and the QRS complex is wide. All right, so I want to talk to you now a little bit about my favorite ventricular tachycardia. And my favorite ventricular tachycardia is called polymorphic VTAC. And polymorphic VTAC is another type of ventricular tachycardia where the amplitudes of the QRS complex changes, and you'll see that. Now, you'll also notice that in addition to the changing amplitudes, you'll also notice that the deflection direction changes, where this is upright and this is negative, then it goes back to upright and negative and back to upright. Now, if you've read any books or you've talked to any buddies of yours, they're going to call this torsades. All right, whoops, torsades. Let's try that again. We're going to call this torsades. All right, it's going to look like this. And this means it's French for twisting of the points. So you'll see that the points, if you want to think about this as spiraling around this central axis here, and these points are spiraling around in a 3D. They're coming out at you, then they're going back into the back of the board. So twisting of the points is a type of polymorphic VTAC, right, which is always abbreviated, by the way, polymorphic VTAC. So remember we talked about SVT, and we said under SVT there's PAT, and there's AV nodal reentry tachycardia. There's all these types of SVT. So the umbrella is SVT. Similarly, in polymorphic VTAC is this umbrella. And under polymorphic VTAC, we can have torsades, and we can have other types of polymorphic VTAC. So all torsades is polymorphic VTAC. All polymorphic VTAC is not torsades. We have no idea if this polymorphic VTAC is torsades or not, and the reason for that is because in order to call a polymorphic VTAC presentation specific type of polymorphic VTAC torsades, we have to know this additional piece of information called the QTC. We'll talk about that in just a second. So let's refresh for just a second. Polymorphic VTAC is characterized by the same thing as VTAC. It's regular, no P waves, no PRs, QRS duration is greater than 120 milliseconds, and the rate is greater than 120. The only difference between monomorphic VTAC and polymorphic VTAC is the presence of a changing amplitude across the EKG tracing, as you can see in this one. So important concepts. Now, in addition to that, in addition to calling this polymorphic VTAC, if we have this additional piece of information, which is the QTC, then sometimes we can call this polymorphic VTAC torsades. I'll get to that. Just give me one slide in 1 second. First, let's confirm this is polymorphic VTach. Is the rate greater than 120? Yes, this rate's right around the 160, 170 mark. Is it regular? Yes, it is regular. Now you're going to see there's a little bit of variance that takes place in here. All right, so the variance is subtle here. There's a little bit of variance, but it's not very much. It might be a half of a box. All right, so count those out and you'll see it. It looks like there's more than that, but if you count them peak to peak, you're going to see that they're pretty darn close. All right, so this counts as regular. There are no P waves that are visible anywhere here. All right, for now. We'll come back and talk about P wave stuff in a different day, but perhaps we can talk about P wave activity that's taking place here, and we'll mention that on a different day. All right, if there's no P waves, there's no PR duration, and you can see here, man, this QRS complex is like 180, 200 milliseconds. It's really, really, really wide, all right? In some spots, it's like 4.5, 5 boxes wide. So really wide, it's fast, and it varies in terms of its amplitude. So this is, in fact, polymorphic VTach. All right, let us take a look at something new here just for a second. Remember when we introduced all of the waves and the intervals that existed on the EKG, we said we were going to come back to this QT interval. The QT interval is the representative of one complete ventricular cycle. And what I mean by that is a complete ventricular cycle consists of a total depolarization and repolarization of ventricular tissue. So the QT interval starts at the beginning of the Q wave and it goes all the way to the end of the T wave, hence the name QT interval. So the amount of time that elapses between the beginning of the Q wave and the end of the T wave is called the QT interval, and the QT interval represents one complete ventricular cycle. Now, within the ventricular cycle here, there are some different additional pieces that we need to know about, and here they are. So if you look at the QRS complex in isolation, and then you add a little bit of a ST and T wave here, if you were to look at repolarization and depolarization, when you get to the peak of the R wave, the peak of the R wave represents the most depolarization that the ventricular cycle undergoes, meaning that the majority of the ventricular tissue is depolarized right at the peak of the R wave. And from the peak of the R wave to about the midway point of the T wave, there is this time period that happens here, and it is called the absolute refractory period. And the absolute refractory period says that if you were to try to send another signal for depolarization during this time frame, it's similar to the toilet analogy, the flushing of the toilet analogy. If you were to try to stimulate the tissue here to depolarize again, you would get absolutely nothing. And the reason you get nothing is because sodium is not back outside of the cells, potassium is not back inside the cells. The cell hasn't repolarized enough to go again. So it is absolutely refractory, meaning unable to respond to any sort of stimulus. Now, from this time period, middle of the T wave till about the end of the T wave, there's this new time period, and that new time period is called the relative refractory period. And the relative refractory period says that if a stimulus comes into this area and it is strong enough, that stimulus will be able to depolarize those cells that have repolarized in the early phases. So during this phase here, some of the cells have repolarized, and those cells are ready to go again, so that if you get a stimulus that's strong enough, then you're going to get a complex, a depolarization of those myocytes that have repolarized. Now, what does that mean exactly? Well, it is believed that if we end up having some sort of large stimulus that happens during the relative refractory period, it is possible for us to develop VFib or VTach as a result. All right, so what does all this mean to us? We talked about the QT interval, and now we're talking about VFib and VTach. That's exactly right. So if we have a patient that has a long QT interval, long QT interval predisposes to VFib and VTach dysrhythmias. So knowing about the long QT interval is important because long QT intervals in general, and we'll revisit this again in toxicology, but long QT intervals in general are bad because they are predictors of VFib and VTach arrest. Now, we're going to talk a little bit more about the QT interval because the QT interval is a rate-dependent interval. So let's take a look at what that means exactly. Whoops. So the QT interval is rate-dependent. So let's take a look here. If we had a rate that was this fast, these are QRS complexes, and we had a rate that was this fast, right? If these could be perfectly separated. If we were to measure the QT interval on the rate that's slower, and we were to come up with the number of small boxes, let's say the number of small boxes equaled 400 milliseconds. Well, if we measure the QT interval that's here, the QT interval that's here is going to be a lot shorter because there's a lot less space in between these things. So actually the QT interval in this one might read out to be 215 milliseconds. So how can we compare these two things if they're rate dependent and the rate is not the same? This might be 60 beats per minute and this might be 200 beats per minute. And if the rate's not the same, then we're going to get a different answer for our raw number. So in order for us to say that a QT interval is long, we have to convert the QT interval to the QTC. And the QTC stands for the QT corrected. And what's it corrected for? Rate. So the QT interval is the raw measurement that you're actually going to count. And the QTC is the QT that's corrected for an underlying rate so that we can compare apples to apples. Now, you don't need to know this formula. Bizet's formula is the formula that I choose to use that's most commonly used. And Bizet's formula says that if you take the QT interval that you measured, the raw QT, and you divide it by the square root of the distance between two R waves, you get the QT corrected. Now, the QT corrected is something you never need to calculate because in order for you to get the QT corrected, all you need to do is acquire a 12 lead and it will actually print the QTC for you. So the QTC is the important number that you're after, and we're going to say that the QTC is age and gender dependent. So based on how old you are and whether you're male or female, the normal QTC value is going to change. So there are actually tables that you can look up what the QTC should be for that patient's age and sex. All right, so next thing we need to consider, we need a field expedient method because unfortunately, if we look at the QTC or to the QTC to see if it's long or not, I don't have time to go look in a table to see if it's long or not. So I'm going to say the QTC is said to be long in the adult patient if it exceeds, right? So QT is long if it exceeds 440 milliseconds, right? This is a rough number. It might be 460, it might be 420, it might be 480. 440 is a reasonable number for us to use. It's a good number for us to use. All right, so remember we started this whole mess back with polymorphic VTach. And I said to you, in order for you to call polymorphic VTach the specific kind of polymorphic VTach, which is called torsades, you have to know if the QTC is long. Because polymorphic VTach only equals torsades if the QTC exceeds this desired length of 440 milliseconds. So let's say we don't know what the QTC is. If you don't know what the QTC is, but you have polymorphic VTach, we call this polymorphic VTach. You cannot assign it this name of torsades. If you don't know what the QTC is, you got to call it polymorphic VTach if it looks like this. All right? If it looks like this, we have to call this polymorphic VTach. Now, if you saw the rhythm, another rhythm before this, And that rhythm looked like this. And if you measured this QTC to be 540 milliseconds, it's long, and if the patient had some sort of cardiac arrest that ensued, meaning that if they started with this and then the next rhythm that you saw is this rhythm, then you could safely call this torsades. But it's got to have a long QTC. So if you show up on the scene and the patient's in this, you call it polymorphic VTAC. If you know what the QTC is, if it's long, you call it torsades. All right, so enough about that. We'll talk more about it in class. Hopefully that is clear as mud for you. All right, so we'll talk more about the QT interval and the QTC and some of the other things we can do with it. And we'll talk about some field expedient methods, some tricks to learn so that you don't have to actually even know a number. You can just look at the underlying rhythm. We'll do that in a separate video. All right, let's move on to one of our last ventricular rhythms, ventricular fibrillation. All right, ventricular fibrillation. So ventricular fibrillation is similar to atrial fibrillation, except that the fibrillatory baseline is actually due to ventricular fibrillatory baseline and not atrial. As you know from the dissections that we did, the ventricular tissue is much thicker, much larger, and has much more mass than does the atrial tissue, and therefore you're going to get a higher amplitude depolarization. The rate here is not measurable, meaning that there are no QRS complexes, but the rate in VFib is somewhere around the 320 to 600 per minute mark, right? Same as AFib. Regularity, absolutely none. No P waves, no PR duration, no QRS. There's absolutely no rhyme or reason and no regularity to this whatsoever. This is called ventricular fibrillation. All right, I think that's all that needs to be said about that one. All right, asystole, there is no rate, there is no regularity, no P waves, no duration, no QRS. There are no discernible waveforms. Absolutely none. Asystole. Again, enough about that one. So now let's take a look at something that happens in a rhythm. This is not a rhythm. Remember we had PACs that came from the atrial tissue, PJCs from the junctional tissue, and now we have PVCs. These are the ventricular complexes, comes from the ventricle tissue. And you'll notice here, if you look at this EKG, you'll find what appears to be a normal P wave followed by a normal QRS. Normal P, normal QRS, normal P, normal QRS. Then you get these horribly terrible looking ginormous guys that show up here. So let's take a look at them. They come early in the sequence. So if you look at the distance here between this guy and this guy, the midway point is kind of like here somewhere, maybe a little bit even more to the right. So this guy started way early. You don't see any P waves before these guys because this is a ventricular rhythm. This is not a rhythm, a ventricular complex. So we get this ginormous and ugly and wide QRS complex followed by a T wave. So PVCs, wide QRS, greater than 120 milliseconds. Discordance between QRS and T, meaning that the QRS is negatively reflected, the T wave is upright, comes early in the sequence. All these things are characteristic findings of PVCs, premature ventricular complexes. Are complexes that occur early in the rhythm, they come early in the sequence, and as a result of coming early in the sequence, we call them premature. So that's this guy that's coming early in the sequence. They are wide, there's discordance between QRS and T. These are PVCs. All right, so I think that covers everything we need to for the ventricles. All right, stay tuned for heart blocks if we haven't listened to those yet.